All right. So, welcome to the sixth session. And today, what we are going to do, diabetes mellitus, complicating pregnancy, right? So, as we have gone through a large portion of it last time comprehensively, so what I need is just to go through some of the things that are more specific to diabetes. In pregnancy than because we had a very good chat about gestational diabetes, right? So what does this mean? Basically this, what it means is we are talking about two groups of women. However, the first group is what we are actually going to talk about today. The first group is women who know that they are diabetic. They have been diagnosed with diabetes, they know that they are diabetic, and at the moment they are on treatment for diabetes. And the subgroup of these women are women who have been diagnosed with diabetics but has not got any treatment or has not gone for any treatment and has defaulted treatment for a long time, and suddenly they become pregnant and come to you. Okay. So the third subgroup or the next subgroup in this are women who are initially in the first trimester, due to our screening process or whatever, we diagnose them as having diabetes. But then, of course, we cannot name them as women with pre-existing diabetes because they are already pregnant, whether they are pregnant in the first trimester or late, still it is pregnancy. So they'll be named gestational diabetes, although we can suspect that they probably had pre-existing diabetes before they came. Okay. So basically now, if a woman, so let's take the preconceptional time to see what we need to do and how we need to manage these patients. So when they come to the preconceptional clinic, all right, so they are having diabetes and they walk in and tell you, doctor, I have diabetes and I want to get pregnant. And then, so is there anything specific that you want to tell me, right? So number one, what we do is, of course, in the preconception, the first thing we need to understand is we need to look at their diabetic control and to find out whether their diabetes is controlled or not controlled. So that is the very first thing. And how do we do that? We do that by doing a HbA1c. Okay. So when we do HbA1c, right, and if it is less than 6.5, what we can say is, look, yes, please go ahead. You're all right. Your diabetes has been or is under control. So please go ahead and get pregnant. So if it is anything more than 6.5, right, then of course we will advise them, please stay, don't get pregnant. We will give you some form of contraception. Until your HbA1c is less than 6.5, it is better not to get pregnant. And definitely, if it is over 10%, right, there's something that's quite uncontrolled diabetes. And therefore, what do we say? Because if it is more than 10%, there's quite a high risk of the patient having a baby with fetal anomalies, because diabetic control is important at the time of conception. When the sperm meets the egg, she should be very well controlled. So definitely, if the HbA1c is more than 10, she is very high risk of having a baby with fetal anomalies. And it's high as 25%. Okay, 1 in 4. You understand? So therefore, any woman preconceptional, if you see, and with an HbA1c of 10, tell her, do not get pregnant. Make sure that you get yourself control, give her contraception, and try and get a HbA1c below 6.5%, and that would then it will be safe for to go ahead with the pregnancy, right? So that is the first very large principle to check for diabetic control in a patient who is having diabetes already. The second thing is, if she wants to get pregnant, right? The second thing is, because she's already diabetic, and if she has not checked for end organ damage in the past 3 to 6 months. So if they tell you a report, okay, see, I got myself checked in the last or last month or 2 months before, then of course you don't need to check specifically. However, if they have not got themselves checked in the last 6 months for end organ damage, then it's extremely necessary for you to have them checked or direct them to a physician or an endocrinologist to have them checked. Okay, and how do you check? The first is what are the end organs that we are worried about? Number 1 is kidney, number 2 eyes, and number 3 neuropathy. 3 things. Okay, right? Remember that. So of course we are looking at macrovascular and microvascular complications, but overall as obstetricians and as students, what you all need to understand is we will check for the damage of these 3 organs and what their status is at the moment. Right. So let's take renal damage, right, or kidney damage. If they're having renal problems, what do we do? First of all, we will check a serum creatinine. Right? If it is anything over 120, right, millimoles per liter, then of course you will need to ask them to meet a renal physician. Okay, and definitely anything over 250, pregnancy is contraindicated, right? And that is chronic kidney disease. So you need to really send them to a renal physician. At the same time, discuss with contraception with them. Definitely, if they are in renal failure and then the serum creatinines are very high, the chance of conception is also very low because they don't basically conceive because they are very ill. Okay, right. Then the next thing is what else can we do to check for renal? Then you can do a urine creatinine, protein creatinine ratio. And what are the things that we look for? Usually we expect the UPCR or the urine protein creatinine ratio to be less than 30, right, milligrams per liter. Okay, so that is something. So if it is over 30, that would mean that the woman is losing quite a lot of protein, and then of course we have to refer her to a renal physician. Remember, we are talking about the preconceptional period. Okay. The third thing which we want to check would be what? The estimated glomerular filtration rate, right? And we expect that to be in the range of about, better to have it over 60, but even 45 is okay, right? And it is milliliters per minute per 1.73 square meter. So that is how it's measured. So you expect it to hopefully to be more than 45. Better, of course, for it to be over 60. So the estimated glomerular filtration is okay. Then these are the most 3 important things, remember, that we need to check for renal function preconceptionally. In summary, what are these? Serum creatinine, children, and we want it to be less than 120. UPCR, we want it to be less than 30. Estimated glomerular filtration rate, we want it to be better over 60, but at least over 45. Okay, so those are the 3 things we need to do. Then comes the second thing, retinopathy. Okay, why is retinopathy important? Because one kind of retinopathy, the eyes, right, will progress during pregnancy. And what is this retinopathy called? That is called proliferative retinopathy. In the retina, you can see the blood vessels proliferating. Okay, and these women will probably require laser ablation of those proliferative vessels, because otherwise they can progress in pregnancy. Other kinds of retinopathy do not progress, so it is only proliferative retinopathy. So she needs to go to ophthalmologist or eye surgeon, right? And get the eyes checked. And if they detect proliferative retinopathy, they will, of course, treat her before pregnancy. Is that clear? The third thing which you had ready, what are neuropathies? So normally neuropathies are quite subtle, but then you can do different nerve conduction studies, right? And test these women for neuropathy, and then if necessary, treat them with the drugs which are used and they are usually being managed by the endocrinologist as well as the neurologist. So basically you screen these women for these three, right, preconception to make sure that everything is all right. Is that clear? Right. So first principle, remember children, is what? To recap, check for diabetic control. If not control, please send them to an endocrinologist or a physician to sort it out. Second thing is we check for end organ damage, and these are what? Kidney, neuropathy for neuropathy, and for eye damage we check for retinopathy, right? And proliferative retinopathy definitely needs treatment. Okay. The third important principle for us in patients with diabetes, sometimes they are overweight. So our desired weight would be a BMI of less than 27. So if they're anything over 27, you will anyway advise them on a diet and try and ask them to lose weight before they get pregnant, right? So a desired BMI would be something less than 27. Is that clear? So that is the desired BMI for these patients preconception. Next, supplementation wise, what do we give? Supplementation wise, one of the main things is folic acid. We need to increase the dose because in patients with diabetes, the consumption is higher, right? So therefore, we will need to increase the dose of folic acid to about 5 milligrams preconceptionally, and that needs to be continued into the pregnancy for about 3 months into the pregnancy. Okay, give me one moment, please. Sorry. Right, sorry. Where, right, okay. What were we talking about? All right, okay. Weight, right? So weight, we need to have weight reduction. The next thing is we need to talk to them about if they are diabetic so that we gain more control and the symptoms, problems will become less. We'll have to talk to them about lifestyle modifications. What are these? Proper diet, proper exercise, and eat healthy. Okay. So we have to advise them on lifestyle modifications at this point. The next. Now, usually, if they come preconceptionally, it may be desirable. Now, this is the next principle, is we need to evaluate what drugs they are on. What are the types of drugs they are not sort of in? We try to avoid ACE inhibitors and statins. So if they are on statins or on ACE inhibitors, right, due to other complications or problems or hypertensions, right, we will try to avoid these pre-pregnancy and for the time of conception. However, if they come afterwards, you will need to change them. And normally, the two preferred types of medication for diabetes are only two, insulin and metformin. If there's a problem with metformin, glibenclamide is a suitable alternative. But for the moment, all the evidence and most of the evidence is going to be with insulin and metformin, right? So there is, if we feel that she might not come and and she may be on other kinds of drugs, then we will try to modify or change her oral hypoglycemics, right, into metformin or glibenclamide, or if she's on insulin, that's fine. Then we can adjust it when she gets pregnant, right? So that is about medication preconception, right? Then the next thing we need to talk to them, right, about is we need to advise them on a few things before they get onto a pregnancy. What are these? We need to talk to them. There are 3 problems in diabetes that the woman needs to be aware of, which may become more, less, or have problems. What are these? This is hypoglycemia, because she is on therapy. Hyperglycemia, right, because it might go out of control, and diabetic ketoacidosis, right? So in pregnancy, because we are trying to, the glycemic control is sometimes may not be good. Remember, because the pregnancy, I told you, they start producing human placental lactogen. So then we give medication, we give insulin, we give therapy, we give diet. So all that in combination can cause her to swing from hypoglycemia to hyperglycemia, and from there she can swing on to diabetic ketoacidosis, right? So it is extremely important for these women to understand the symptoms, right, of hyperglycemia as well as ketoacidosis. So in the preconceptional clinic, it is important for you to counsel them and advise them. Look, these are the features of hypoglycemia, which you know very well, right? I don't need to teach all that. Or these are the features of hyperglycemia or worsening control, which you all know very well, hopefully, right? And then I know if I ask you all, you all say tuck, 1, 2, 3, 4, 5, 6. So of course, I'm sure Chamod, next time I meet you, I'm going to ask, so please study, right? And then you have to be very thorough with the signs and symptoms of diabetic ketoacidosis, right? So these are the things we have to tell the patient, right? Okay, be on the lookout for these and please seek medical help if necessary, right? Then these are the basic facts in the preconceptional period that you need to tell the woman and advise her about, right? So let's move on from the preconceptional clinic. Is there anything that you want to ask me about the preconceptional clinic? Do you understand? These are the advisors that you need to give these women before they get pregnant. But the main advice, remember, have good tight control before pregnancy. Remember, if they are not under control and they are not getting followed up, please refer them to a diabetic physician or an endocrinologist or a physician, and to make sure they get all their end organs checked, make sure that they are well controlled, and give them contraception till then. Okay. And of course, rest of the general advices in a preconception stands for them, but this is very, very specific advice which you need to tell them. Okay. Right. Any questions from anyone before we move on? Right. Then they come to the first trimester. So all the rest of the principles of a normal pregnancy applies, right? But in the first trimester, there are several specific things that you need to think about. Number one, we will now, there will be already on 5 milligrams of folic acid, right? In the first trimester, in the booking visit, we will start them on aspirin, 150 milligrams of aspirin on a daily basis, because that will reduce their chances of having bad placentation and will reduce the chance of them having pregnancy-induced hypertension, right? So aspirin, we will start routinely in the first trimester for women who have pre-existing diabetes, right? Second thing is, if the second principle is we need to adjust or change the medication that they are already on, right? If that has not been done already, remember the two kinds that are usually medication that are usually indicated are what? Insulin and metformin. Maybe glibenclamide, but metformin and insulin has the most amount of evidence for them. So if they are on any other kind of drug, for example, sulfonylureas or any other kind of drug, right? Normally, those are considered for the moment as contraindicated, and you convert them to insulin and convert them to metformin, right? So that is the most important thing for drug adjustment, which you need to do in the first trimester. And if they are still on maybe statins, and if they are still on ACE inhibitors for other medication, for other problems, then you will need to stop them and convert them into alternative drugs for these, which you can do in with the participation of a physician for that matter, right? So those are the important things for drug changes, right? And of course, you might, because they may be on different, so if they are already on insulin, they may be on different kinds of insulin. So therefore, for the moment, most of the evidence, and for you all to understand, is that we have what? We give short acting, or we can call them ultra short acting or short acting insulins, right? Which will cover the immediate meal. And then we cover the night with a long acting insulin, which is normally isophane insulin. Okay. So short actings is you take the insulin and the woman needs breakfast. Take the insulin and the woman needs lunch. Take the insulin and the woman needs dinner, right? And then at 10 o'clock normally, the long acting or the isophane insulin is the best for the woman, is given, and then it controls the diabetes overnight, which will be reflected in the fasting blood sugar, right? I forgot initially, remember the target values in the preconceptional period for the woman to have is between, we expect them to be between 76 and 126, right? That is the target value. Even 95 to 126 is all right, right? So that is the target value. During pregnancy, our target values are between 76 and 126, okay? Right. So, remember, they may be on different kinds of regimes of insulin. They may be on synthetic analogs. They may be on different kinds of short-acting, long-acting, right? Different regimes like mixed-art, maybe 24-hour acting. They may be on different kinds of regimes. But the safest and the simplest, which gives us the most control, is always what? 3 fast acting or short acting insulins to cover the or pre-meal insulin with a long acting, which is normally isophane insulin in the night, right? Remember that, children, that is more than enough for you all, because it is the postgraduates who are going to discuss the pros and cons of each regime, the evidence behind that we will ask them. For you all, it is more than enough to understand how it's controlled at the moment. And the metformin doses, children, is what? We can, if the metformin, the evidence is for metformin to be given between 1,500 per day up to 2,500 per day. 1,500 is 500 milligram TID or 3 times daily. That can be different adjustments can be made up to about 2,500 milligrams per day. If still the control is not there, then that adjustment will go with insulin and not with metformin. So we do not continue to increase metformin. So once we reach metformin the maximum, and then we continue to change the doses with insulin. Is that clear? Right. So number 1, management of the medication or change of the medication. Change over from things which are not very reliable and with no evidence to things that are reliable, which is basically insulin and metformin, right? Glibenclamide is given only if metformin is not tolerated or metformin cannot be taken, right? Then the next thing what you have to remember is if they are only on metformin, you continue doing or giving metformin up to about 2,500 milligrams per day. And only later, if still control is not achieved, you do not change over or add another oral hypoglycemic agent, right? Which means you do not combine metformin with glibenclamide, right? But from the time you reach the maximum of metformin, you add on insulin for control. Is that clear, children? Right? So this is how you increase the dosage. So we are just talking about the booking visit now and specific that we need to do. The next thing is in the booking visit, remember, if they have not, one moment. Right, sorry. Where were we?
Metformin.
Right, okay. So you go on to the maximum of metformin and then switch on to insulin if necessary, right? Then now I have lost the thread. Now, so
Booking visit.
sorry.
So you were talking about what we do during the booking visit.
Okay, right. So for the first thing that we have to remember is that I spoke to you about aspirin, right? 150 milligrams. We continue folic acid, 5 milligrams, right? Then we have to discuss or change the medication into the safest forms, which is 3 short-acting insulins plus long-acting isoflurane insulin in the night, right? Then we change over different regimes to the simplest form possible. Then metformin, we can continue up to or go up to about 2,500 milligrams per day and then add on insulin and change depending on that, right? So the next thing is, the next principle is, if screening has not been done for the end organ damage, which I spoke about in the preconceptional clinic, you do it. Right? So what is the simple question? Have you been checked? Has your kidney functions been checked? Has your nerves been checked? And has your what is the eyes been checked in the last 3 to 6 months? If the answer is no, you get it done, right? Or you go send it to a relevant physician to get it sorted. Is that clear? So that is the assessment of end organ damage. And of course, if the renal problems, you might need to refer to a renal physician to manage her alongside you in a pregnancy. The next important thing is, we have to make sure the next one is about her medical or her nutrition, medical nutritional therapy, as to how she is conducting her nutrition. If she is doing it under advice, then of course it's fine. She can continue the same. If she is not doing it under advice, then of course we will need to send her to a dietitian, right? And get her diet sorted out. Is that clear? Right? So next principle is to look at her diet, and then of course discuss next thing is lifestyle modifications. What are these? Normal restricted sort of exercise during the during her pregnancy, right? So balanced diet, right, and exercise. And then of course if the BMI is very high, of course we don't let them diet during pregnancy, so that may not be able to, we will not be able to help that. So we will need to have to manage her accordingly, because there will be more complications in an overweight woman in pregnancy. So we might need to increase the surveillance for her during a pregnancy. Okay. Next, we have to offer them screening, right? Different kinds of screening, because they are at a higher risk of having genetic and fetal abnormalities, right? So therefore, initially first trimester, remember, we can offer them down screening, we can offer them this quadruple test, the triple test, the double test, and of course you can offer them the DNA, free floating DNA, or they are called non-invasive fetal testing, can be offered during this time as well, right? And by ultrasonically, yes, you can do the nuchal translucency, the nasal bone, and check for gross anomalies at this point. So these are the specific things that we had to discuss in the first trimester, other than the other things. The next important thing is we must take a bit of time off during the minute to talk to them about the three things that I spoke to you about the preconception clinic. What are these, children? What do we need to take to them? Features of hypoglycemia, because they can die with hypoglycemia. Okay, because they are on different kinds of therapy. They are not, maybe they are dieting, may not be eating well, and then they give insulin. They are given insulin. They are given special insulin, which can cause severe hypoglycemia and even death. So we have to talk to them or advise them about hypoglycemia, features of hyperglycemia, which can then, of course, the features of diabetic ketoacidosis. Okay. So these are the important principles in the booking visit, which you need to keep in mind when there's a patient in front of you with diabetes, pre-existing diabetes. The next thing which you need to speak to them about is what and how we are going to monitor them during pregnancy, right? And how frequently. The best would be self-home glucose monitor. Okay, if they can check their glucose, even with the capillary, which may not be accurate, but they have a different set of cutoff values. But if they do home blood glucose monitoring, self-home blood glucose monitoring, that is the best, because then the woman is checked every day, and the insulin doses can be adjusted. However, it might not be very feasible in Sri Lanka. So the next best thing that we can do is what? Is to monitor them with a blood sugar series, right? And the blood sugar series, there are different blood sugar series, but the most practical probably is a blood sugar series with a fasting blood sugar, which is from after about 8 to 10 hours fasting, and then 1 hour post breakfast, 1 hour post lunch, and 1 hour post dinner, right? Usually a pre-meal is not very important, because most of the problems that we encounter, like shoulder dystocia, macrosomia, all these problems are more often connected with the postprandial blood sugars, because if they are high, the chances are that we might get, the baby might have macrosomia. So therefore, we are trying to aim at the postprandials and not the preprandials. And what are our target values of blood sugar? The 8 to 10 hour fasting value should be less than 95 grams per deciliter. and the first hour value, if that is done, should be less than 140 milligrams per deciliter. And if the second hour value is done, right, should be less than 120 milligrams per deciliter. So a blood sugar series may be like this: fasting, 2 hours after breakfast, 2 hours after lunch, and 2 hours after dinner. If that is performed, then our targets are what? 95 for the fasting and 120, 120, 120. Is that clear, children? If you do a blood sugar series with fasting and 1 hour post lunch, 1 hour post breakfast, and 1 hour post dinner, then our values are less than 95 and less than 140, 140, 140. Do you understand? Right? So why 140 at the first hour and 120 in the second hour? Because with time the body produces glucose, insulin, and the blood sugar will go down. So at 2 hours, then we expect the body to have done something and brought the blood sugar levels to less than 120. So that is our expectation. If we are not hitting that, and if the values are high, then of course, what do we need to do? We need to adjust our medication, right? To bring down the blood sugar levels so that it is within the acceptable range of what we just discussed, right? So this is how the control is monitored over time. So those are the general principles, of course, that we need to go with in the booking visit. And these are the specifics that we have to consider when we are looking at a woman with pre-existing diabetes mellitus, right? Next, normally, if the woman, so next probably we are looking at about 16 weeks, right? And what is special about 16 weeks? If the woman had retinopathy, right, in a pregnancy, and if it was not treated, then she should be evaluated by a eye physician, right, at 16 weeks to see if the retinopathy is continuing. Normally, she will be checked at 16, then again at 24, right, and maybe again around 32 weeks for diabetic retinopathy through her pregnancy. Is that clear? Right. And then once we do that at 16 and she's referred and that's sorted, the next time we are going to meet her will be around between 18 and 21 weeks. And what is this for? Remember, with diabetes, there can be fetal anomalies, right, and problems. And then we need to do a comprehensive fetal anomaly scan between these times, right, to check whether there are any pre-existing anomalies. Remember, any system can be affected. There can be renal anomalies, cardiac anomalies, any system can be affected. But normally, there are one anomaly which is very specific to women who are having pre-existing diabetes and with fever. That is sacral agenesis. The sacrum disappears. Okay. So if you see a sacral agenesis in a baby, then probably that was due to, not always, but maybe due to diabetes or pre-existing or uncontrolled diabetes. Is that clear? However, cardiac, renal, or any other system can have anomalies, and these anomalies are commoner in women with pre-existing diabetes, right? So from the booking visit onwards, remember, with the rest of the things, then you need to talk about monitoring with blood sugar series. Depending on the circumstances in the unit, it can be weekly, it can be home blood glucose monitoring, right? It can be different types, and the frequency can be different. But in Sri Lanka, practically probably we are looking at 2 weekly blood sugar series, which we need to monitor them. And again, remember, what is our targeted value for monitoring? Fasting less than 95, and the 1 hour postprandial should be less than 140. And if the 2 hours are done, then we are targeting, or we are hoping that they should be less than 120 milligrams per deciliter. Is that clear? So now we have gone through the anomaly scan at 21, and next normally we will meet them around 24 weeks. Why? If they are having, or remember, we need to direct them for to check for diabetic retinopathy at that time, right, if necessary, so that they get another eye check, or if there is proliferative retinopathy, then it to be checked around 24 weeks. And of course, at 24 weeks is the best time to do a fetal echocardiogram, right, to check for fetal cardiac anomaly. If you are suspecting that between 20 in the anomaly scan at 21, the best time for them to go for a fetal echocardiography is between 22 and 24 weeks. So you can refer them to a specialist who does this, a cardiologist. There are cardiologists who does especially fetal echocardiograms, right? And there may be fetal, there are fetal medicine specialists who do fetal echocardiograms to detect fetal cardiac anomalies. So that can be arranged at 24 weeks, right? At the same time, from 24 weeks, then we start to measure their growth, serial symphysiofunnel height measurement, and we can start serial growth scans from about 24 weeks, right? What does serial growth scans means? We are looking at, we can serially measure the baby's growth, the estimated fetal weight, the abdominal circumference. We can do the Dopplers serially, and then of course if you want, you can measure the serial symphysiofunnel height, but usually that is not very accurate because it is like trying to guess the weight of the driver by looking at the vehicle. Okay, so usually it is not a very effective way. So since we have a scan, probably the most logical way would be for if the facilities are available for serial ultrasonic growth scans. So and of course we need to measure another two parameters. What are these? If diabetes is not controlled, the baby can have polyhydramnios by scan. The baby can have macrosomia, which is detected by scan. And if the presentation is not good due to diabetes, the baby can alternatively have small for gestational age, or the baby can be small. And at the same time, if there are kidney anomalies, the baby can have oligohydramnios as well, right? So those are things that you need to watch out for in the subsequent serial scans, which I started at about 24 weeks. Is that clear? And remember, with these patients, the chances of pregnancy-induced hypertension also goes up by about 30%, and therefore we need to be on the lookout for that. And so again, our next review week will be around 28 weeks. Okay. So during the second and the third trimesters, the whole thing basically lies on several facts. What? Control of blood sugar diabetes with various medication. Control or checking serially checking the Dopplers, the growth, the abdominal circumference, estimated fetal weight, the amniotic fluid, right? So you serially check the baby and chart them and plot them, and then you just go monitoring this mother and the baby for problems. In the mother, three things: hypoglycemia, hyperglycemia, diabetic ketoacidosis, and polyhydramnios will cause her to become uncomfortable. Okay, so these are the things that you need to remember during the second and the third trimesters. Is that clear? Right? So then, once that is done, we approach what? The timing of delivery. And so timing of delivery, children, is very, very easy to remember. Right? The principles, all these are not hard cut rules, but the principles are what? If there are complications of diabetes, either to the baby or the fetus, you can deliver the baby anytime. And do you understand? So if there's a huge problem, you deliver. You can't just wait for either the baby or the mother to suffer. Is that clear? But it's like you measure, okay, when is it safest, best time and the safest time for the mother or the baby? And if one of is compromised, then you try to think of a time of delivery. So if there are complications and problems, you can deliver them before 37 weeks, right? Any patient on medical nutritional therapy only, MNT only, and fully and well controlled biochemically and ultrasonically, you can go up to 40 weeks, right? And in some units, you can go up to 41 weeks, but usually for up to 40 weeks would be acceptable, okay? Next, any patient who is having medical nutrition therapy in combination with oral hypoglycemic drugs like metformin and fully controlled ultrasonically as well as medically and by every other feature, you can continue the pregnancy up to about 40 weeks or so. Is that clear? Any patient on insulin, it is better to get the baby delivered by about 38, 39 weeks because the chances of intrauterine death can go up. So we don't wait till about 40. So we will deliver between 38 and 39 weeks. Is that clear? So those are the general guidelines that you need to remember. Again, if you want to time the delivery, any complications happen for the baby and the mother, you deliver anytime. Okay? Fully controlled medical nutrition therapy, only fully controlled means biochemically as well as ultrasonically as well as clinically and every fully controlled, you deliver 40 or 41 weeks. Usually it's acceptable to say 40 weeks. Fully controlled medical nutrition therapy plus even metformin, fully controlled, you can go up to about 40 weeks. Okay. If the patient is on insulin, you deliver by about 38, between 38 and 39 weeks. Is that clear? So that is the timing of delivery which you need to be, which you need to understand. Clear? Then the mode of delivery. Usually, vaginal delivery can be achieved in any of these. The only thing is sometimes the cervix may not be favorable and therefore you might need to ripen the cervix, put in prostaglandins and then go for a vaginal delivery. But vaginal delivery is the preferred and it's not contraindicated in diabetes. Is that clear? The only time that you might think, okay, should we go for a cesarean section? Not if. Of course, if there are absolute indications for cesarean section, you go for cesarean. If the lower segment is, say, if there's a placenta previa or if there's a large fibroid occupying the lower segment, right? Then, of course, anyway, there's no option. Maybe 2 or more sections done, right? So then you can think of a elective cesarean section. The next thing is very large babies. Say if the baby's weight is over 4 kilograms or even 3,800, 4,000 grams, right? Then of course, maybe in diabetes, you might want to think, okay, should we go for a elective cesarean section? So macrosomic babies, it's not an absolute indication for a cesarean section, right? Or it's not and definitely not a contraindication for a vaginal delivery. So depending on the unit policy and your experience, right, you might decide to go for a vaginal delivery or a cesarean section. But most clinicians, if the baby is very large, right, and relatively, if we feel that there is a problem in delivery and there's a higher risk of shoulder dystocia or dystocic birth or birth trauma to the baby, you might want to think of a elective cesarean section at that point, right? Of course, if it's a large baby and a past cesarean section, then you are not going to go for a vaginal birth after cesarean. So therefore, it's better to go for a elective cesarean section. Got it? Remember, if there are no huge risk factors and if it's a past cesarean section, even if it is diabetes, if the diabetes is well controlled, baby's average size, pelvis is okay, no specific problems, head is well engaged, and if she goes into labor, there is no contraindication for a vaginal birth or a trial of vaginal birth after a cesarean. So remember that you can try to go for a vaginal birth after cesarean if everything looks favorable, but with a very low threshold to go for a cesarean section if anything happens during labor. Do you understand? So remember that as well. So if you ask, is vaginal birth after cesarean contraindicated in patients with gestational diabetes or pre-existing diabetes or patients with insulin, the answer is no. It is not contraindicated. If things are favorable, you can go for it. And if definitely if she goes into spontaneous labor, you can. But you need to have a low threshold. That is how you answer. Low threshold for a cesarean section, because if the labor is not progressing, if there are signs of obstruction, there are signs of course, fetal distress, of you have to deliver. So if the labor is not progressing, then you can go for a cesarean section by monitoring them very well. Is that clear? So we have discussed timing of delivery comprehensively, and we have discussed mode of delivery comprehensively, right? Do you understand? And place of delivery, of course, where there are neonatal facilities, and during the labor, there has to be a, during delivery, there has to be a neonatologist, because there is a possibility of shoulder dystocia. Why is there shoulder dystocia? It is thought that the ratio of the baby's shoulder girth appears to be larger than a normal baby. So even a woman with diabetes giving birth to a normal sized fetus, and the baby might have shoulder dystocia because of the difference in the width of the shoulders or the fat pad. It is thought that because it's insulin-like growth factor 6 is higher in women with diabetes, they go across to the placenta, and that causes the increase in the amount of fat deposition in the shoulders. So therefore, the fetus is at an increased risk of shoulder dystocia, even the baby is normal sized baby. Is that clear, children? Right. So that is the timing of delivery and the mode of delivery and the place of delivery, right? And next segment is that now we have to come to the delivery segment, right? If we are going for an elective cesarean section, remember, or any cesarean section, preoperatively, the diabetes need to be well controlled. Our target values are always between what? 90 and 126, right? Or 95 and 126. Some might say 75 and 126, but somewhere within that range, right? They need to be well controlled. They have to take their medication until the day before, before they start fasting, right? And so that medication is continued. If insulin, you stop the insulin at the day of the surgery, but the before night, overnight doses can be given, right? They need to be optimally hydrated, fully controlled before they go for a elective cesarean section in the preoperative period, right? Operative period, of course, you all don't need to really worry about that. And the post-operative period, they are prone to what? They are prone to hypoglycemia, and sometimes they maybe have hyperglycemia, right? And they might have problems there. So you need to be very careful in monitoring their glycemic control in the postpartum period in operative delivery, right? In a normal delivery, remember, if these patients are only solely on medical nutritional therapy, well controlled, no difference in the labor, you can go with the same thing as a normal patient. Okay. If they are on metformin, usually we would have stopped the drugs in the morning on the day of the labor. So you have to monitor their glycemic control during the labor. If they are on insulin, right, and we will need to continue this insulin, there's a possibility if the glycemic control is not adequate. So the completely throughout the delivery, we want our target is to keep the glucose levels between 90, or shall we say 75 and 126, or some units will say 140. So if you just say our intention is to keep the glucose levels between 75 and say 126, right, which is adequate, right? So that is our target during the pregnancy. And how do we achieve it? Number one, first of all, to know whether we are achieving it, we have to monitor. So that means hourly capillary blood sugar measurements throughout the labor. Okay. Second thing is, what is very important is hydration is extremely important in diabetes, because the patient can get dehydrated very quickly. So hydration must be maintained well, and the urine output needs to be maintained well as well. Third thing is, how do we achieve glycemic control in patients who have been insulin dependent. We have to go for a sliding scale. Okay, which means there's a specific sliding scale which says this amount of capillary blood sugar, we need to give this amount of insulin per hour or minute, right? And so what do we have? We have a specific sliding scale, right, to tell us how to adjust the insulin. Insulin is going separately into the woman with a syringe pump. Usually we put 50 units of insulin into 50 ml of normal saline. So there is 1 ml has 1 unit, and then that syringe pump we can adjust for the rates to go into the mother. So it can be 1 unit, 2 units, 3 units, depending on the sliding scale. Okay. Then if the woman becomes hypoglycemic due to our insulin, if the CBS drops below, say 75, we call it a problem, then there should be a separate dextrose drip going into her, right, to increase the blood sugars quickly. So that can be switched on if the blood sugars are falling. So we need to push in glucose into her. Is that clear? And then with if she is going into hyperglycemia, then of course we have to increase the amount of insulin. But of course, we also have to, into that drip, with the insulin or with the hydration, we have to push in potassium as well. So usually 20 to 40 millimoles of potassium is put into a normal saline drip for the normal hydration, and that goes into the patient constantly. And we adjust the insulin, right, depending on the hyper or hypoglycemia according to sliding scale. And throughout the delivery, we are planning to keep it between 75 and 126 milligrams per deciliter to make sure that everything goes smoothly. Is that clear? Delivery in the third stage of shoulder dystocia is common, so you need to get a pediatrician or a neonatologist or a pediatric house officer to attend the delivery essentially, right? Is that clear? After delivery, it is important to manage the third stage of the labor, which I have explained to you, hopefully, right? Yes, I think I have, right? The active management of the third stage. And what is the problem that we can have? Number one, postpartum hemorrhages are common because the uterus may be over distended due to polyhydramnios and it might not contract very well. Second, trauma is commoner because of our maneuvers with, if the baby is large, then there is a possibility of maternal trauma, and of course the baby can have trauma, and at the same time the trauma can be, and also there's shoulder dystocia. When we try to do a few things, then of course there may be maternal trauma. So postpartum hemorrhage is commoner, and trauma to the baby and the woman is also commoner, and trauma also can cause hemorrhage as well. Remember the 40s that can cause postpartum hemorrhage. You have tone, uterus does not relax. Then you have thrombin. What does that mean? The coagulation factors have gone down. 3, you have trauma, right, which can also be due to, as I told you, large baby or when you try to do maneuvers. And 4th is what? Tissue. Tissue is retained placental tissue. Do you understand? Those are the 4 things that can cause postpartum hemorrhage. Of that, in diabetes, the problem is usually with what? With the tone, right? Uterus does not contract very well, right? And because of the diabetes, maybe the placentation is also not good. The blood supply also to the uterus may not be excellent to cause everything for the mechanisms to work, and therefore you can have postpartum hemorrhage. Is that clear? Then we come to the postpartum period. Remember, in immediate postpartum period, any of the 3 is possible. What? Hypoglycemia, hyperglycemia, and ketoacidosis. You need to watch them very carefully. And therefore, monitoring is essential in the postpartum period. They may have all the problems. There may be infections, commoner. They can have breastfeeding problems, psychological problems. All those problems can come with the mother. So we need to monitor the mother very carefully. And then Somebody has asked, sir, can you please repeat the 4 T's? Okay. This is something else which we'll discuss anyway, children. This is the postpartum hemorrhage. I just mentioned it. Okay. First is T is tone, which is the commonest problem because the uterus refuses or does not contract very well. So when because there's hypotonia, then it begins to bleed. The second one is tissue, which is retained placenta. Tissue is retained within the uterine cavity, so the uterus cannot contract and prevent postpartum hemorrhage. So if there's placental tissue left, right, you can have bleeding. Number 3 is trauma. Any trauma to the uterus, to the cervix, to the vagina, to the vulva, right, can cause bleeding. So therefore, the third is a trauma. 4 is thrombin. It is just an abbreviation for coagulation disorders, right? So where the coagulation factors are deficient or relative deficiency, it can cause bleeding. So those are the 4 important factors that can contribute to postpartum hemorrhage. This is out of the topic, but just because I'm answering a question. Okay. Next. So postpartum period, what do we do? If the woman was on medical nutrition therapy, immediately after delivery, we should take off the diet, and they go back to their normal diet, right? Sorry, if it is a woman who has been on medical nutrition therapy for pre-existing diabetes, they go back to their pre-pregnancy diet, right? So whatever their diet they have been taking pre-pregnancy control diabetes, they do. If the woman was on any form of medication pre-pregnancy, you put them back on their pre-pregnancy medication so that she continues that after delivery. If the woman was on insulin, right, then you continue the same dose of insulin she was pre-pregnancy, because once the placenta has gone off, then the body will start to become used to the same pre-pregnancy insulin which she was getting, right? If there was a very, very badly or very high doses which are during pregnancy, you have to be careful about taking them off completely. So you might need to seek advice of a physician as well, and then slowly tailor down the insulin only if she was on very high dose of insulin during the pregnancy, right? Do you understand? If we added insulin during pregnancy, but she was on say medical nutrition therapy plus metformin before pregnancy, you can just take the insulin off and start on those pre-pregnancy therapies and then continue to monitor blood glucose levels afterwards. Do you all understand? So this is how we stop or continue or tailor off medication for diabetes for this patient. Is that clear? Right. And of course, at the end of 6 weeks, she goes back to her normal physician who is taking care of her diabetes, right? So that covers the whole of specific things that we do for patients with diabetes, and then of course they go back to their normal control, right? So that is how diabetes is managed. Right? Any questions so far before I go on to the questions that have been sent? Yes, you can type in or you can ask, whatever you want. Feel free to ask. Oh, you all asked. So I'm okay. Okay, now I have a question. Hurrah. How do we advise the patient on home blood glucose monitoring? Well, children, the targets are the same. The targets are the same between 76 and 126. So home blood glucose monitoring ideally needs to be done maybe randomly 2 to 3 times a day, but ideally it should be done, say a fasting 1 hour post lunch, 1 hour post breakfast, and 1 hour. So the same blood sugar series you do at home, but with the capillary. And sometimes the levels, remember, those what I told you are the venous cutoff levels, but they can be roughly applied to the capillary blood sugar level, and they monitor it at home. And therefore, depending on the values they get, they can adjust their medication on a daily or at least every 2 to 3 days, right? Okay. Right. Questions? Could you please repeat what to monitor post-op in elective LSCS? Right. So, after a cesarean section, Vanshigam, remember the general monitoring is there. I told you about the general principles, which we will anyway discuss at a time where we are talking about the post-operative period. So there are different kinds of what is important in the as far as blood glucose is concerned, right? Soon after delivery in the post-operative period, in about 2-3 hours, capillary blood sugar needs to be done, right? And especially if she's diabetes and on medication, or usually we do not restart insulin or all that unless the blood sugars are extremely high. We try to monitor them, say once 2 to 3, every 6 to 8 hours, we can check their CBS and to make sure that it is under control, right? How long do you continue the aspirin for? Wait, there are 2 questions. So how long is an? Usually the recommendation differs. It is thought it is best to continue it for about 34 to 36 weeks because it also reduces the chance of pregnancy-induced hypertension. Some will continue it until delivery. No harm, because you can even continue right up to delivery if you want. Usually it is not continued after delivery. Is there a place for pre-meal glucose level monitoring in diabetes in pregnancy? Yes. Pre-meal, the problem is it's very difficult to correlate the complications with pre-meal ones, right? And therefore, when do we do it? 1 hour pre-meal, 1 hour, it's very difficult, right? And sometimes the biggest problem is, now say you tell the patient, okay, do a pre-meal 1 hour before you eat. So they do a glucose, and then they will so just before a meal, so they can do it, but the values are a bit difficult to understand. So therefore, it is easy to give a glucose load to a patient or a human being and measure what the body does with it, right? Than to think that we can measure what is happening about the glucose in the body when they are about to eat. You understand? Because so that itself is a bit of a maybe not a very specific thing to do. So therefore, it is thought that the post meals are better, or they better represent the glucose controls. Right. Okay. Now the questions are coming in. Are there differences in the anomalies in the fetus in a pre-existing ops? Are there differences in the anomalies in the fetus in a pre-existing diabetes mother and a gestational? Yes. The chances of a gestational diabetes mother with gestational diabetes and fetus is very small, right? Remember, most of the fetal anomalies are connected to the diabetic control at the time of conception, right? So in gestational diabetes, properly there is no diabetes at the time of conception. Okay, so definitely the chance of fetal anomalies are higher in diabetes, while it's almost the same as a non-diabetic woman in pregnancy for fetal anomalies, right? What's a diagnostic test to confirm pre-existing diabetes mellitus in pregnancy if PPACs at booking visit is high? You can't confirm diabetes mellitus in pregnancy. If there are no past history, it is always termed as gestational diabetes. Diagnostic test is always the same. The oral glucose tolerance test, there's no difference. Screening test can differ. Diagnostic test is always the oral glucose tolerance test, but we discussed long about the values. Please check my last session. And then monitoring is always done with blood sugar series. So they might change, but I have discussed the types and different ways of blood sugar series which you can do. Normally is GDM patients at the time of delivery is 40 weeks and to GDM pregnancy is 39 weeks. Yesterday patient time of delivery is 40 weeks and right. I don't really understand this question. We are talking about diabetes, right? And this is concerned with the timing of delivery, which we have already discussed, right? So I told you the timing of delivery is always dependent on whether the patient is on nutrition therapy only, whether the patient is taking oral hypoglycemics with nutrition, whether the patient has complications or not, or whether the patient is on insulin, right? Those are the things that we have to consider. What is the most important appropriate BSS value, 1 hour or 2 hour? Personally, I use the 1 hour values. However, the 2 hour value is also acceptable. But there is some evidence, slight evidence to say that some of the complications may be more connected with a 1 hour value than with a 2 hour value. So therefore, I personally use 1 hour. However, that is 2 hour value is equally acceptable and can be used. So it's best for you to choose one type of blood sugar series because you can't ask the patient to do 1 hour and 2 hour postprandials, right? From my personally, I do 1 hour, but the evidence can change and the practices might change at any time when new evidence comes up at a later stage, right? So you can choose either. Remember, 1 hour is 140, the 2 hour is 120. Okay. Is there a place for HbA1c as a measure during the first trimester? Children, HbA1c alone will be just a screening test, like any other thing. Postprandial blood sugar or urine sugar or a dipstick or a 1 hour postprandial or a random blood sugar, or it'll be just like another screening test. If it's high, you need to do oral glucose tolerance test anyway, right? So yes, it has as a screening test, right? What are the effects of AC inhibitors and statin during pregnancy? AC inhibitors can cause renal problems, right? And therefore, they can cause renal blood vessel problems, and they can cause small for gestational or growth restrictions. Statins, there may be problems with the lipid metabolism, so we don't use those during pregnancy. Is there an added risk of stillbirths in gestational diabetes compared to pre-existing? No, there is no added risk. In pre-existing diabetes, there is a higher risk, right? In gestational diabetes, it's uncontrolled gestational diabetes. Yes, there is a risk because it is thought that the sudden increase in glucose inside the fetus, right, or sudden huge surge of glucose causes the heart to stop or arrhythmia. So therefore, that is the reason. So therefore, in uncontrolled gestational diabetes, it might happen. However, in pre-existing diabetes, it is higher. What we should consider when advising family planning method for diabetic patient after delivery? It depends on their wishes. Now, if they want sterilization, yes. If not, it is long-acting reversible contraception is the best, right? LARCs. HbA1c can be used to follow up. So can HbA1c, no children, now follow up of what? During pregnancy, no. It is always blood sugar series. After pregnancy, remember 6 weeks, it's a physician that takes over. So they can monitor with anything they want, right? It's basically the obstetrician says bye-bye and 6 weeks, it's you hand over the patient. Okay? Because pregnancy changes in the postpartum is up to 6 weeks, right? Okay, then you hand it over to our colleagues, physicians, right? or general practitioners. I mean, depends on whoever they are following up with. Is the risk of IUG or SGA higher with gestational diabetes or pre-existing diabetes? Pre-existing. Is there no difference? Like, yeah, because with pre-existing diabetes, what happens is the placentation may be inferior, and therefore you can have problems, right? Normally, gestational diabetes, you get larger fetuses, as with the pre-existing, but the chance of having a SGA and a IUGR is higher with pre-existing because the bad placentation that can occur in that. Though it is not GNOMs, I do not understand what is estimated GFR as opposed to simple GFR as a renal function. Right. Estimated GFR is calculated taking into a lot of things into consideration, right? So it's given in milliliters per minute per square, 1.723 meters squared. Okay, so that is the proper way of calculating. So it's a combination of lot of factors. So actually even age comes into consideration. Age, the creatinine levels, the weight, lot of things come into consideration. So it's given as a value. So that is why there is while glomerular is an actually measured value which can be given with different things. So that is the difference there. So don't worry too much about that, children, right? So could you please repeat when we start aspirin? Aspirin, children, first trimester. You start in the first trimester, 150 milligrams, right? Folic acid, you start preconceptionally. Aspirin, you start in the first trimester. Okay. How long do we continue aspirin for? Is it omitted before labor? Usually, yeah, before labor it can be omitted, or at least up to 37, 38 weeks you can continue. How long do we give it for? Probably aspirin, no? Yes, so same. Does GDM or pre-existing diabetes delay lung maturity? Yes. Now, gestational diabetes, pre-existing diabetes, has a problem or causes problems with surfactant production. Because of the pneumocytes, there are pneumocytes in the lung. There are pneumocyte 1 and 2, and surfactant is produced by one of those, and therefore the function is slightly deranged. Therefore, the surfactant production is low. So, in a gestational diabetic patient or a pre-existing diabetic patient, the baby's maturity is lung maturity is slightly low. So, they have commoner chances of having pulmonary problems. So, the answer is yes. Please discover the principles of contraceptive methods in the next session. Okay. Right? I think she's just talking about general contraception, right? Yeah, we will have definitely we will have a discussion about contraception as a separate entity, because that we need to address about the principles of contraception. So we'll do it as one gynae session, right? All right. Okay. So that seems to have ended the questions. Do you want me to answer any more questions, or do we close the session? It's 11 o'clock. Enough for today? Yeah? Chamod, are you sleeping? Right. So do you want me to? Yeah. So I think we'll close the session. It's almost 11 o'clock, right? And I also have a very busy week ahead. Okay. Right. Right. Somebody wants to do fetal monitoring during pregnancy. Yes. Right. So definitely we will go for labor management and its principles in a different session, right? Because we need to talk about, I'll take a CTG class for you all, the principles one day, right? So that will be about monitoring. Then I will talk to you about the management. So we'll take separate classes for that in the future, right? So next, you all want me to talk about, what do you want to talk about? then we'll discuss a gynae topic. So once I decide, I will put it on the, so please prepare your questions, children. All right, for say if I put PCOS, have some questions ready so you can immediately type it in. For me to receive them and bring them up in forum and then discuss them will be more tedious for me. So please have your questions ready, because you all know the topic beforehand. It doesn't matter SCQs or MCQs or whatever, just type it into the chat, then it becomes easier for me to immediately answer them than because I'm also quite busy. So so therefore let's just quickly do it online so that I can answer the questions then and there for all the rest of the topics. Okay, right. So we'll close the session. Is there another one? Endogenous steroids increase glycemic control in pregnancy. No, they do not increase. They worsen glycemic control in pregnancy. Okay. Right. Okay then. Good night. Right, and we'll meet next Wednesday. Okay. Bye bye.
Good night.
Good night.
Thank you.
Good night. Good night.
Good night. Thank you.
Good night.
Thank you, sir.